left a message. Let's start. Rashmi, go ahead.
Just half a minute. We are live now.
A very good afternoon to all the respected seniors, friends, and the viewers of this series. I extend a very warm welcome to all of you to Foxy Clinical Research Committee's webinar series E3, wherein the first E stands for evidence-based medicine, which is the base of this series, and excellence and experience, which we are striving hard to gain from our teachers and mentors. I welcome you all with my co-conveners, Dr. Monica Desai, Dr. Jaya Kore, and Dr. Archana Kumari. And I would like to invite Dr. Surekha Taide, who is the chairperson of this committee, to propose a welcome address.
Thank you very much, Rashmi, and good evening, everybody. Our respected guest of honor, Dr. Charmila, our chief guest, Dr. Jaideep Tang, sir, will be joining soon. And our speakers, Dr. Manju Puri, then we have Dr. Mitra Saxena, our chairpersons, Dr. Parikshit Tang, Dr. Komal Chauhan, and Dr. Suvarna Kadilkar, and of course, the convener of the series, Dr. Rashmi Kahar, and the coordinators, co-conveners, Dr. Archana Kumari, Dr. Monica Desai, Jaya Kore, and all the participants and viewers of this series, which is aptly titled as E3, which is evidence, because we are basing all our talks, our discussion on evidence. We have experienced speakers, teachers of our excellence who will be conveying the key messages and talking about very important topics. And definitely we want all of us to excel in what we are giving our community, giving our patients. So that is how we have started this E3 series. And the E3, this is the third episode. And every time we pick up a very important topic, not only obstetrics, but we will be going towards gynecology and infertility as well. So we'll be picking up key topics of importance, and then we invite experienced speakers to speak and share the knowledge. So today we are here with the theme all about LSCS, and we have our guest of honor today with us, who is Dr. Charmila Ayaung, who is not only the VP of this year, but she is the in charge for our clinical research committee, and we are very, very proud and we are honored that Dr. Charmila is, heading and in charge of this committee, which is Clinical Research Committee. She has been the former chair of the Clinical Research Committee, and during her tenure, Clinical Research Committee has shown and excelled in each and every, way she has picked up the projects, the themes of that year. So everybody remembers Clinical Research Committee from Charmila's tenure. So we also know that she is doing so very well as the ICOG Governing Council member and other organizations as well. She has collaborated with UNICEF for various projects, the Medha project of Foxy, Gurukul project, and overall, she has been doing a lot of work on menstrual hygiene as well. She's doing work with gestosis, and I remember her, work in Trichy, the society she's come from. So we are eager to hear from you, Dr. Charmila, and for guiding this series. Over to you.
Thank you. Yeah, thank you so much, Surekha. I am more honored to be in charge of Clinical Research Committee because such great work and all different work. And as you said, research is was not taken up so much, but last year it did so much work and all different themes you have taken up. And today's webinar, the E3 webinar, all about LSCS is something unique, I would say, because people don't stick on to one topic. They generalize, and sometimes we lose our perspective sometimes. They've got such excellent speakers, Dr. Manju Puri ma'am. Anytime, she's one of the best teachers in India. And you also are giving a talk, and Dr. Mitra Saxena madam is also giving a talk. All wonderful speakers, great chairpersons, and great conveners. Dr. Reshmi, Dr. Monica Desai, Dr. Jaya Kore, and Dr. Achana Kumari. I'd like to wish Clinical Research Committee all the best, and I know you'll do extremely well this year and the next year also. We're eagerly waiting to see your work. Thank you so much, Sureka.
Thank you. Thank you, Charmila. We always will be, guided by you for all our work. Thank you so much for being with us and for supporting us. So over to Rashmi for the academic sessions.
Hi, thank you, dignitaries, and we would like to move forward to our scientific session. Over to Jaya for first session.
Thank you so much, respected Charmila ma'am, for your gracious presence and for blessing this webinar. So moving on to our first scientific session, that is difficult abdominal entry in LSCS. We have esteemed speaker for this, respected Dr. Manju Puri madam, and we have chairperson Dr. Parishit Tang sir. Because of some emergency, sir is not able to join. Maybe he will join later. So I will request Dr. Surekha Tade ma'am to please chair this session.
Yeah.
And
Thank
to
you so much,
introduce anyone.
Manju. Sorry, Jaya. Jaya is my own student, and I am really proud of the way she's going ahead in the organization. So I would like to, of course, Dr. Manju Puri, we know as a very, very excellent teacher and trainer and a guide to so many students. And we have seen her in so many platforms training in such a way that knowledge comes from her heart. And she's been the director professor at Department of OBGY at Lady Harding's and president of NARCHI presently at Delhi branch. FRCOG, last year I think madam has received, and we were so amazed by the type of work she has done. A movie call award for the best scientific. In the last 2 years, she has received so many awards. The LH Lobo oration, Leelavati oration, Suman Kher oration, the CS Dawn, CL Zaveri, and Srimati Bhagwati Yamuna Singh. I think these are the best prizes for her presentations. The Foxy Achiever Award, last year's again, the APJ Abdul Kalam Excellence Award, again 2023, Teacher of Teachers Award in 2017. Madam, we are so blessed to have you here, and it is so, feel good feeling when you are there on any platform. And we are eager to hear from you about a topic on LSAs, that is difficult entry, which is again a very, very important topic. And over to Madam for her lecture. Can you stop sharing and allow share to Madam? Yes, ma'am.
Thank you, Surekha, and thank you, team Foxy Clinical Research Committee. And Team EMOGS also, I think, is kind of, coordinating the whole thing. So thanks for inviting me to be talking on this very, very important topic. And thanks for a very, very gracious introduction. So I'll start sharing my screen. And please let me know if my screen is visible.
Yes, it is. Please, ma'am.
Right.
Go ahead.
So, the topic given to me is difficult abdominal entry during cesarean section. So, we all know that the profile of mothers undergoing cesarean sections is changing, and conventionally difficult abdominal entry was associated with the previous abdominal surgery and obstructed labor. So it was, we never used to get too many such difficult situations, where we would get entangled in. But with the rising cesarean section rates and the number of cesareans which every woman is undergoing, so most obstetricians operate upon mothers who have previous multiple surgeries. Additionally, there is a significant increase in the maternal obesity, especially morbid obesity. The burden of difficult abdominal entries consequent to morbid obesity also is adding onto the burden of difficult abdominal entry. the entry can be challenging, irrespective of the number of previous cesarean section. It is not only that previous one would not have and previous two you could have this kind of a situation, but you should be mentally prepared for any of the cases, even if it is previous one, to get into this kind of trouble. So most cesarean sections are done through Fenton steel incision. Initially they always used to be done through vertical, so it was so much more easier to go above the umbilicus and open the peritoneum there. But I think because most of them are done by Fenton steel, where there is limited exposure and your reach to the peritoneum higher than umbilicus is also not there. So I think these are the problems which we will address. I will address during my talk. Now, just a view of surgical anatomy of anterior abdominal wall. This is important because we should understand we have these anterior superior iliac spines here, the pubic symphysis here, and this is the pubic symphysis. These are anterior superior iliac spines, and we normally would give incision 2 fingers above, finger breadth above the pubic symphysis, and that is what is Fenton steel. And if we give Joel Cohen incision, that is higher than our Fenton steel. But Fenton steel is just about 2 finger breadth above the pubic symphysis. So we should know what all structures come in our way. So we open it the usual way, first the skin, then the fat, then we cut the rectus sheath transversely. Then we have the recti in the center, we separate the recti. And once we separate the recti, we get to see the peritoneum, we open the peritoneum and we go in. Right. So normally we do not face any kind of difficulty here because right below that you will have the lower uterine segment. So what you need to remember is that, one is that you have this inferior epigastric artery. Can you see this artery going up? So if you give a low incision, this is quite far away. But if especially in obese patients, when we give a supraumbilical incision, so this is quite close by. So you have to keep this in mind that, this is running right underneath the recti. So that is why we say don't poke in your fingers before opening the peritoneum under the rectus sheath. So, we always say that if you have to retract the rectus muscle, please cut the peritoneum and then put a retractor in. So I think that is what is important for you to know. And also important is that midline entry is very easy. So when you do a midline vertical incision, so you have all the advantages, right? So again, looking at the placement of incisions, so you have the Fenton steel, which can be high and which can be low. We normally would use the lower Fenton steel incision. And the typical Maillard is higher, but we also can convert the low Fenton steel incision into Maillard incision. I will just highlight, talk about it in my next slide. And if you look here, this is where I was telling you that above the arcuate line, that is, that the posterior rectus sheath is present only in the upper 1/3 of the anterior abdominal wall. And this is the arcuate line. This is the posterior rectus sheath. This is the anterior rectus sheath. So you can see that if you go above the, arcuate line and nearer to the umbilicus, you can see that this is the superior epigastric artery, which is coming from above. Whereas if we are below this is the level where we are, and you can see the inferior epigastric artery is here, right? It is away from this. So it doesn't come in our field. It comes only if we have to do a muscle cutting incision. So that is the importance of showing you this picture. Now, all of us should be familiar with Maillard's incision because these incisions do help when we have difficulty in opening the peritoneum or gaining entry into the peritoneum through the midline. So we must do a muscle cutting incision, and there should be no hesitation in doing it because you see here that if you cut the muscle on both the sides, the muscle fibers would retract. The only bleeder which comes is the inferior epigastric artery. So you need to make sure that you ligate the inferior epigastric artery on the top and bottom on both the sides so that they don't get injured and there is no hematoma formation. And once you have cut these muscles have got retracted here, and you can see the whole peritoneum is open in front of you. So even if you can't enter the peritoneum through the medial plane, you can always go laterally because you can see that peritoneum there. And the adhesions are only in the midline because that is where you had opened the peritoneum in your previous cesarean. So adhesions are likely to be only in the midline and they don't go on the side. So that is what it is, So that is why it is very, very important to know and not to hesitate in cutting the muscles. So this is what is Maillard's. You also call it Mackendorf's incision. As far as the peritoneum is concerned, you can open the peritoneum either in transverse or in vertical. Normally we open it in vertical, but you can open it either in transverse or in vertical. But in case you open it in transverse, then we have to secure the, cut the urachus. Now, Cherney's incision. What is Cherney's incision? Cherney's incision is tendon cutting incision. So basically, you go low down, you dissect normally, when we open give a phalanstele, we keep the pyramidalis muscle towards the abdominal wall. Okay. So when we mobilize or we cut when we separate the pyramidalis from the rectus muscle, and so that when we open the peritoneum, the pyramidalis does not get injured. But, in this case, what we do is that in this case, the pyramidalis is kept along with the rectus muscle, and you go down below and you can go and reach the tendons of the pyramidalis and the tendons of the rectus muscle. So once you see those tendons, you can, with the help of a knife, you can cut those tendons. And when you cut those tendons, make sure you leave about 0.5 centimeter of the tendon along with the pubic symphysis, because you have to reattach the tendon. So once you see here that this is the pyramidalis muscle, the tendon is being cut with the help of a knife, and you can see the whole thing. This is the remaining bit of the tendon. The whole muscle is retracted up. And then again, you have that full excess of the peritoneum. You can see it so well. So that is what is the importance of this. And you can open it. And once the surgery is over, in this case, you have to restitch the part which you have retracted up back to either to the remaining part of the tendon which was there, or you can attach the upper part also to the rectus sheath, the inner side of the rectus sheath, with the help of non-absorbable sutures. So that is very, very important, because you've cut the tendon. It is not the muscle, it is a tendon which you have cut. So these are two, incisions which you must know how to do, and they will help you in, circumventing the problem of adhesions which are found in the midline. Now, adhesions we know is the biggest hurdle when we talk about difficult entry, and the degree of decision formation is unpredictable and it is variable, and it is common after cesarean birth, and the extent and density, they increase with the increasing number of repeat cesarean births. But there is a whole lot of individual variation. We have seen patients even with a single cesarean having a very, very bad midline adhesions. The reported prevalence of adhesions is 12 to 46% of patients at their second cesarean, and 26 to 75%. It's almost the double of patients in the third cesarean section. The main concern of all obstetricians when you encounter adhesions is the impact of increased incision delivery interval on the immediate neonatal outcome. So everyone is in a hurry to bring out the baby, and when you find adhesions and you don't get into the planes, so if you become rough, then you are likely to cause trauma to the uterus, myometrium, to the bladder, to the bowel. All these things can be injured. So studies have shown that there is a minimal impact of prolonged cesarean delivery interval on the 5-minute Apgar score. So a lot of studies are there. It has been debated quite a bit. And moreover, what has been shown is that it is the what is more important is the uterine incision to delivery interval. So that they have shown should be less than 4 minutes. So once the uterus is exposed, then there is no delay in delivering the baby. So remember that you have good about 180 to 240 seconds, right? So almost 4 minutes you have. So that should not be prolonged. But even if that is prolonged, it does not cause much damage, right? So basically, do not count the skin incision to delivery interval. Count the uterine incision to delivery interval, which should be kept at less than 4 minutes. Now, this is the worst kind of scenario which we come across. And I'm sure everyone who's an obstetrician would encounter this kind of a situation. That is when the uterus is stuck to the anterior abdominal wall in the midline. right? Just below the fundus onwards till the lower part. It is absolutely stuck to the anterior abdominal wall. And this is where you enter when you open the abdomen, right? And then you don't know how to go about. So I think this is something which is very important. And we will have a look how to get over this kind of situation. Now, what are the basic principles of adhesiolysis? Make entry from a virgin area. So that is why we say, even if you have done a Ferron steel, you try and go separate the muscles as high up as possible near the umbilicus, and then kind of, open the peritoneum there. And the basic principle is that once the baby is delivered, you know that the uterus would be almost at the level of the umbilicus, right? So even if the adhesions form, they are there only from below the from the level of umbilicus till the pubic symphysis. That would be the area where the adhesions would be. So, we try to go as high as possible and open the peritoneum there. And be mindful of the presence of adhesions at the previous incision site. So we always open the peritoneum midline vertical, and that is why the adhesions are there onto the anterior surface of the uterus in the midline. So, and in case there are midline adhesions, you can't open it, then consider opening the peritoneum laterally away from the midline by either converting your incision into a Mackenrot incision or a Maillard incision or a, Cherney's incision. Because then you have the whole peritoneum in front of you, right? So open the peritoneum carefully after lifting a peritoneal fold between two artery forceps and ensuring that it is thin and transparent. Do adhesiolysis layer by layer. So don't pick up an adhesion and cut it straight. So thin, layer by layer, cut it. Use traction and counter traction. Use sharp dissection. Keep the vital structures, bowel, bladder, and uterus in mind, and trace the omental adhesions to its attachment, either to the uterus or to the bladder or to the parietal peritoneum, and then cut it from there, right? And ensure hemostasis during adhesiolysis. Sorry. So this is the video I'm going to share, and this was made in Lady Hardinge Medical College by Dr. Aruna when she was a professor with us. So, using a cautery, cutting cautery is very, very useful. You can see that she's mobilizing the muscles from the upper part of the rectus sheath. The muscles all seem to be plastered. You don't see any space in between the muscles here. So she's nicely mobilizing the whole thing. And, you can use scissors, but there's no point doing blunt dissection. So it has to be a sharp dissection. And, similarly, the lower part is being mobilized. So again, cutting cautery is being used, and scissors are being used to mobilize the muscles from the rectus sheath. Now we come to the midline. So that is normally what we do. So we try and, separate the two muscles away from each other. But here they all seem to be plastered. There doesn't seem to be any space, right? So what is being done is that with the help of artery forceps, layer by layer, the adhesions are being opened. But the whole thing seems to be very plastered here. So, so you try doing it. It is usually not so hard. This is one of the unusual ones, which was very hard. So, she's just trying to, and imagine the amount of force which is being used. It means there's so much of fibrosis here. So just trying to get into a space, trying to go up. Okay, and here she seems to be holding quite a thick adhesion, but when she cuts it, you will see she's cutting bit by bit. Not that she's cutting the whole thing, and again, she's trying to go layer by layer, right? So that you don't cut anything in between. Making sure that there's nothing in between. Again, trying to kind of open it up, but it seems to be absolutely plastered. Now, one thing which you have to, and see, you always work with the tip of the knife. With the tip of the knife, you can cut the whole thing, and bit by bit you cut. So you are not going to damage the bladder. That is what you must remember. So if your finger is behind it, you know how much thickness is there. So it is not going to harm. So, whenever while you are giving incision and there's so much of bleeding, it means that you have actually damaged the myometrium. So that means you're going deep. That is what should come to your mind. So here again, she's saying there's so much of fibrosis here. So trying to go on the sides, that is what we said. But here we always have that worry that we may not damage the inferior epigastric vessels, but in the phalansteal, we know that they are quite far off. So it is not that they are very close by. So here, a decision to cut the muscles is taken, because that is what was obstructing, because we can't get any entry in the midline. So now we need to go to the side. So here you can hold it with 2 clamps and you can cut it. Okay, and you do the same. Now the lower part is being cut. Again, an artery is there behind it. And with the help of a tip of the knife, when you cut it, you can see a nice yellow plane here. So that is where the peritoneum is. So now this is comfortable. So at least we got a plane. And once you get a plane, then it becomes easy, because then you can, cut the tissues, keeping the plane in mind. So this is the other side muscles which we are cutting. It's quite fibrotic. And now once you put in your finger, from inside, I told you the adhesions are only going to be up to the level of umbilicus. So you can always put your finger up and bring the adhesion into your feet. Is it right? So once you hold it, now you can cut it, because you're sure, because you already felt that there was no bowel or anything there. And now this part is done. All these bands have to be cut. So once these bands are cut, and now see how nicely it is being sliced transversely. She's not going deep, but she's separating the muscle from the peritoneum underneath, right? And another band there, putting a finger below it, you can hold the band. So these are very thick, moderate to severe adhesions. So now once these adhesions are gone, and you can see that now we are there in the low uterine segment, and you can see the head which is popping up, right? So now you can push it, because this is the right plane, and there's nothing which we need to be worried about. So this is a typical kind of a case which we come across when there is a midline adhesions from the fundus going up to the low uterine segment, right? So now, can we predict adhesions? So one is, we must always do a detailed record review. So any details of previous surgeries should be looked up, any laparoscopy she's had. It's always nice to look up, so that whether, for all she might have documented proof of adhesions being there, which you have not seen. Second is, on clinical examination, you all must have experienced that sometimes the uterus looks much bigger, as far as the height is concerned, although the bulk may be small. Say, even if it is 10 week size, you will feel as if the height is at 16 weeks, but overall bulk is less, right? So these are the kind of uteri, if you have seen them in the early pregnancy, and these are the ones which you should understand that they will be adherent in the midline. And of course, restricted mobility when you do a PV examination in these patients when they were non-pregnant. Please jot it down, so that whenever they become pregnant, it's easy for that obstetrician to know that there's going to be technical difficulty. Then we have a sliding sign. So it is a relative motion between the abdominal wall and uterine wall, as assessed by ultrasonography. So if you ask the patient to take deep breath, she breathes deeply, and you can see the abdominal wall sliding over the uterine wall. And in case it is not sliding in that area, in the lower part, lower abdominal wall, then it would mean that the sliding sign is negative. So it is an independent predictor of moderate to thick adhesions with acceptable sensitivity. The sensitivity is not high, but it has got a very high specificity. So once it is negative, it means that patient is bound to have, adhesions. And this sign has been shown to be significantly associated with higher incidence of adhesions, longer skin to delivery interval, longer total operative time, and lower 5-minute EBGAR in newborns. Now, obstructed liver.
I think Dr. Manju ma'am got disconnected. We have Dr. Parikshit Tank here. Sir, welcome to the E3 webinar series, and nice to find you with us to express your experience. What was going on was difficult abdominal entry during the LSCS, and while we wait for Dr. Manju ma'am to come back, we would like your opinion and your comments.
Yeah, I think it was an absolutely fascinating video that we were looking at, and all of us were completely spellbound with the description, as well as the thought process which went into the surgical planning. Dr. Puri is, of course, one of the most erudite practitioners that I've come across, and always shares some great insights into clinical problems. Unfortunately, we seem to have lost connection. I'm sure she'll join back in a while. Uh, so, a lot of difficulties that we face in a relatively simple procedure like a cesarean have to do with their antecedents in previous events. Most common reasons why one has difficulty while entering and before the delivery, that phase between the incision to the delivery of the baby, the most common reasons for difficulties are the fact that there's something abnormal on the abdominal wall. There is something abnormal beneath the abdominal wall, and there is something abnormal on the uterus. So you can think about it at three levels. So when we say something abnormal on the uterine wall, it could be multiple scars. You have to think about how you are going to plan your incision. Often there is a debate about whether a transverse incision should be made when there is a previous a vertical or a paramedian incision. But I think now more or less we have kind of resolved to the fact that the transverse incision is probably the most versatile one as far as obstetrics and cesarean sections are concerned. Then adhesions, as Dr. Puri was talking about, I think she has just joined back. So
Yeah, please go continue for a while and
yeah.
please complete your
So the adhesions form the most common reason why we face difficulties. Another common reason why we face difficulties are, previously placed meshes. For example, somebody who's had a hernia repair, and then you have to go through that. Then what are you going to do about getting that back onto track? And then, of course, deeper down into the peritoneal cavity, if you have a large fibroid, for example, which is obstructing the lower segment, then those can be potential difficult entries. So I'll stop there and let Dr. Puri carry on from where she's left off. Ma'am, pleasure to be chairing this session, and it's always great to listen to you.
Thank you, Dr. Tank, and my apologies for this technical glitch. So I think Dr. Tank was making very pertinent points about having patients who have meshes in place and who have cervical fibroids. So I'll move on to the obstructed labor. So obstructed labor is not so common, but obstructed labor with previous cesarean would be very, very challenging. And especially if a patient has phenol-steel incision. So all these combinations is going to make the entry even more difficult. And one might consider a vertical incision in advance as well, or think that you will have a Chinese incision in this case, so that you have ample adequate space to go well above the umbilicus. You have to have peritoneum well above the umbilicus because the bladder is really advanced, right? So that is where the challenge would be in obstructed labor. Then for morbidly obese mothers, what are the challenges? Now, this is, as the class of obesity increases, so especially class 3 and class 4, where, the whole anatomical distortion is there because they have a big, panniculus, which is hanging, and it becomes very difficult to palpate the pubic symphysis or the anterior spiralic spines. Secondly, in these cases, they have, because that panniculus is always hanging. So there is anaerobic environment underneath the panniculus. So that is why we avoid giving incisions under the panniculus. So even if the patient is class 1 obesity, we say don't go into the crease, because that is where a lot of anaerobic organisms will be there and the patient is likely to have infection. Then, of course, when there is a panniculus and you go through the panniculus, there is a whole lot of fat there. So we would always try to go through an area where the fat is limited. So this is how it looks like. So this is different, grades of panniculus which are there. So this is grade 1, grade 2, grade 3. Here it is almost coming to the mid thighs, and here it is below the knee also. So this big is the panniculus, right? So, this is how these are the levels of the panniculus as compared to the, the patient, when the patient is standing upright, and it hangs like an apron. So, if you look when the patient is lying down, so you need to plan incision with the patient standing. So when she comes to you for normal delivery, even if cesarean is not planned, so you must always plan the proposed site of incision and document it there, so that at the time while she is being mobilized for surgery, someone would know that this is where the incision has been planned. And we plan the incision based on the pubic symphysis and the anterior superior iliac spine. Although these are they are you're not able to palpate, but then when the patient lies down, so we allow the penicillus to hang the way it is, and with the penicillus, the umbilicus also comes down. Okay, the umbilicus is also pulled down. Normally, the umbilicus would be somewhere here. So here the umbilicus has gone down. So your incision, you must remember, would be supraumbilical. Okay, it will be supraumbilical here. And this is the projection of the symphysis pubis. This is the projection of the lower uterine segment. The umbilicus is here, right? So this is the pubic symphysis here. The umbilicus is here. And this is the penicillus, which is present in the apron position. So you don't have to lift up the penicillus and then give an incision below it. So you go above the penicillus. I think that is what you must remember. So likewise here, if you see here, this is the umbilicus here. This is the penicillus. This is the umbilicus here, right? And this is the pubic symphysis, and this is the anterior superior iliac spine. Okay, so here see the incision has to be much higher than the umbilicus. So you don't plan your incision based on umbilicus, but on the on the penicillus and proposed projected point in relation to the pubic symphysis. So this is this would be so much centimeters higher than the umbilicus in this case. So this is sometimes the supraumbilical incision may go as high as this, because the umbilicus gets pulled down. Okay, and this is where the normal fenestrel would be. So this is from Tixier et al., published in Ecta Obstetricia and Gynecologica. So if you see here, so this is the head end, this is the head end, and this is the foot end. So this is the umbilicus towards the head end, and this is the projected site of the incision, right? And that is the place where hand is placed is, that is the upper, that is the, this is the projected projection of the pubic symphysis. This is the umbilicus, this is the penicillus, and that is the place where the incision is going to be placed. So it is going to be placed so high up. And this is how the incision is placed, and the penicillus is hanging here. And you go through the same way like we will go in a fenestrel, and you reach the lower uterine segment here, right? So in case we would have given it in relationship to the umbilicus, our incision is always below the umbilicus. Here it is much above the umbilicus. So to conclude, you must anticipate adhesions in mothers with previous scars, review previous records, assess for any adhesions, any signs of adhesion. On your clinical examination, as far as the PV examination is concerned, or when you do a per abdomen examination, when the height of the uterus appears to be more than the period of gestation, discuss the likely challenges with the patient. Tell her that you might have to change the incision as well. Otherwise, following surgery, the patient can create a problem. Then be mindful of the anatomy, important structures in close vicinity, right? You must always be mindful that there's going to be a bladder there, bowel up, and myometrium posteriorly. The likely site of adhesions, you will remember that the adhesions are always going to be in the midline when we talk about parietal peritoneum and anterior surface of the uterus, and transversely when we talk about the bladder and the lower uterine segment. Okay, use sharp dissection or cutting cautery while opening various layers of the abdomen till you reach the visceral peritoneum, and enter the peritoneum through a virgin area away from the previous incision, generally above the level of above the level of umbilicus. Do not hesitate to convert a muscle into a muscle cutting incision or give a vertical incision, and plan and document the site and type of proposed incision, especially in obese, in a standing position with penicillus hanging as an apron. And always remember that you might have to go quite a few centimeters above the umbilicus. Do not rush to extract the baby unless there is fetal distress. Take your time, right? You know that skin incision to uterine incision is not as important as it would be uterine incision to extraction of the baby. And remember, it is the uterine incision to delivery time that is important, and you have good 3 minutes to deliver the baby once you have exposed the lower uterine segment, right? And in cases like what Dr. Tank was referring, in case you know, we do a fibroid mapping, with good ultrasounds now, we know where the fibroid is. So if you're suspecting a cervical fibroid, you can always give a midline vertical incision right? Depending on whatever is the size of the fibroid, and never kind of, compromise on the incision. That is what is my advice to you, that, at the same time, we don't want that you should give vertical for all, but then wherever, you can always assess. So what is important is that the problem should be anticipated. They should be anticipated, and the solutions should be planned beforehand before we move on with doing any kind of surgery. And as far as the meshes are concerned, you can go through the mesh and then you close the way you close it, right? So that is how the meshes have to be handled. And thank you so much for patient hearing. Yeah.
Thank
It
you
was
very much.
wonderful talk, ma'am.
Over to the chairperson.
Yes, absolutely brilliant exposition of the difficulties and the techniques that an obstetrician can use, and something which is really food for thought, because one may not always know in advance. So this has to be something which is always stored in the back of our minds, but ready to use when the situation arises. Thank you, Dr. Puri. Thank you, Dr. Taide, for your kind invitation, and I really enjoyed being a part of today's program.
Thank you so very much, and lovely comments. And definitely, I think it was worthwhile to listen to both the speaker as well as the chairperson complimenting each other, and I think the audience is benefited by this, sort of the collaboration between the two. So I think it was wonderful to have you both with us. And really, I think, Madam, you're the teacher of teachers, as everybody says, and today we experienced it. Thank you so very much for being with us.
Thank you so much, respected speakers and chairpersons. For second session, over to you, Monica, ma'am.
Thank you, Jaya ma'am. It was indeed a wonderful talk, Manju ma'am and Parishit sir. Thank you so much for your comments. We move ahead with the second talk. Our chairperson for today's session is none other than Dr. Komal Chavan madam. And the speaker will be Dr. Surekha Taide madam, and she will be speaking on difficult cesarean section. Can we have the CV slide of Dr. Komal ma'am? Madam is a vice president-elect, and she has been the chairperson of the Foxy Medical Disorders in Pregnancy Committee for the AMOX Family Welfare Committee. And she has been a part of the Managing Council member of the Mumbai OBGY Society, and she's also the Governing Council member of COG. She has been the premises secretary of AFG also. She has many publications to her credit. We welcome you, ma'am, as a chairperson for today's session.
Thank you. Thank you so much, Monica, for the kind introduction. And it is really great to come for the webinar hosted by the Clinical Research Committee. And Dr. Surekha Taide is doing amazing work as a chair of the committee. The lecture which Dr. Manju Puri madam has given has so much practical insights. And cesarean section being one of the commonest surgery now. Earlier we used to call that MTP. It was the bread and butter, but now I think cesarean section everybody does. And the more we do it, the more there is a difficulty coming because of the second, third, sometimes even technical difficulties. So I think the abdominal entry was very well discussed, but after abdominal entry, the cesarean is still not easy. The cesarean can be difficult because of the difficulties which we encounter during cesarean section. And to throw a light on this topic, we have none other than the chairperson herself, Dr. Surekha Taide. She is my very dear friend. And I think we will also compliment each other, Surekha. She is an eminent speaker, a very great academician. I think she has done wonder in the work which she has done in her local society and at national level. So many GCPRs she has released. And I think the sky is the limit. She is going on and on. The immense year of teaching experience she is having. So over to you, Dr. Surekha Taide, for your talk.
Thank you very much, Dr. Komal. And you yourself being a teacher and with so much experience, I think, again, we will be complimenting each other for this very important topic on difficult access, the difficult C-section. We will be, talking about other things apart from the difficult access. So let me share my screen. I hope it is visible.
Yes, it is visible. Just make it full screen.
Yeah, just a minute, please. Yeah. So I bring greetings from a medical college, which is Jawaharlal Nehru Medical College. And I always, talk about the simulation lab where we teach not only our postgraduates and early career individuals, but also our peripheral health workers. So it's a very beautiful simulation lab, and I invite all of you to be with us someday. So the approximately 1/4 of our emergency C-sections are performed in failure to progress, and they are in the second stage. So this is one part where we find a lot of difficulty. The number of C-sections in the second stage have been rising. And the contributing factor is again the prolonged labor and greater reluctance to performing instrumental delivery. I was discussing just in the morning with Dr. Mitra, and we were talking about how, dwindling the instrumental deliveries have become. And that's why, we are going into those cesarean sections which are conducted in the second stage, and there the difficulty comes. So we have difficult access, which Dr. Manjupuri talked about. We have the obese patient. We have the big baby, that is a difficulty. We have the very small baby, that would be a difficulty. The placenta previa, nacrita, the high floating head, and later on, maybe problems may arise if there is an extension of incision, or which could be a transverse extension or a vertical extension. So there are very many challenges which can occur in the second stage. And in the second stage, the higher complication rates and morbidity is again because there is a difficulty in delivery of the head. There could be an extension of the wound. There could be a broad ligament hematoma and a higher risk of PPH. The fetal injuries can occur, and poor Apgar scores, admission to neonatal intensive units. So basic rule is when you are dealing with difficult situation, first and foremost is the anticipation, the preparedness, staying calm when you are dealing with challenges, not panicking, being very gentle when you are doing the processes. And after the situation is in control and the procedure is over, reflecting on what has happened, absorbing the lessons learned, and then sharing the lessons with the peers and debriefing of the team and yourself as well. These are the basic rules when we are talking of difficult situation. Life is full of difficulties. You have to meet them, read them, and defeat them. So let us go to our first case, a 28-year-old unbooked second gravida, previous C-section, 33 weeks, obese, had severe preeclampsia with a lot of ascites. She also had pleural effusion. Her blood pressure was high. She was started on labetalol. She did not respond. Magnesium sulfate was given. USG showed an absent flow in the umbilical artery. So after completion of the steroid dose, she was taken for cesarean section. The estimated fetal weight was 1.2 kg, a small baby, obese lady. So what anticipated problems were there during the cesarean section? We thought of, this is a small baby, the lower segment would not be formed, there's a lot of ascites. So depending on this, what were the precautions taken is a planned team effort with a good anesthetist. What was very important is the positioning of the patient. So standard practice is to position the table, you have to give that 10 to 15 degree tilt. Obese woman, you have to arrange for a bigger table. That is also important. Your anesthetist has to be a trained person. Retraction may be difficult, so a good assistant is needed. So very important when you have a small baby to deliver, to have a good assistant. In case of ascites, here the large ascites was there, so you have to take care of the spillage. So 2 drains have to be there, 2, suctions. That is what I'm talking of. So as to drain off the ascites, and then you will be able to reach the baby, that area, the lower segment. And herein, there is a possibility of hypotension. So our anesthetist has to take care of the hypotension. LUS is not very well formed. So you have to take care of that. And closure also may be difficult. So in this patient, the lower segment was not formed, the bladder was advanced, patient was obese, retraction was difficult, approximately 1 liter of ascites was drained, the baby was only 1 kg, had to be shifted to an ICU, and mother had all the biochemical and hematological parameters, those who are abnormal initially, later on they became normal. So in this case where, low birth weight babies have to be delivered, the uterus is less distended and lower segment is not very well formed, myometrium is thick, the area over the lower segment is also small area is available. So your incision has to be little deeper, it becomes bloodier, it may be inadequate. So you have to, there is a possibility that there could be a laceration to the fetus. So you have to be very careful. And once you extend, if you extending with fingers, there is a possibility that the uterine vessels may damage. So you have to extend the incision with the help of scissors, planned and, upward directions. Due to small uterus, the bowel also can come in the operative field. So be very careful that you do not injure the bowel. Occasionally, one might have to take an inverted T-shaped incision if you're not having a proper, adequate area to remove the baby. Small fetuses also have delicate bones and tissues more prone to injury. Hence, fetus need to be grasped very gently and extracted very gently. So this is all about the low birth weight babies. Second case is about a previous cesarean section. Here you can see that this patient reported it labor pains. She had scar tenderness and she was taken for cesarean section. On opening, you find that the whole of the cesarean previous scar is very thin along its whole length, and the uterine wall was completely deficient. Almost the visible bulging fetal membranes you can see, and baby could be seen moving underneath, these visible membranes. So always a dilemma. Yes, where should we give this incision now? This is the lower segment. What is advised is that you have to give a incision a little higher up here, and because the incision gets retracted once you remove the baby, and only a small thin area, a small thin flap of the lower segment is left. So you have to be careful while opening and open a bit higher up. So here you can see in this patient, this was the incision, the bulging membranes, the incision was given. This is a small thin, tissue left behind, which have to be closed very carefully. Sometimes it gets retracted. The lower part, the lower edge gets retracted below the bladder. It's very important that you pick up only the lower segment. Sometimes it happens that the posterior uterine wall gets picked up. So very important that you identify the upper and the lower flaps very well and suture carefully in this kind of cases. Now we come to the third difficulty, which is a deeply impacted head, usually in the second stage of labor, which we get deeply impacted. So here again, the lower segment is thinned out. The risk of tears are there, broad ligament injury, bladder injury, maybe is a possibility. Cervix is taken up, risk of a cervical or vaginal incision is there, liquor is drained off, and there is difficulty in extracting the baby. Available options with us, you can deliver with the vertex, pushing from the head from below, which is called as the abdominopelvic approach. Deliver the shoulder first, that is the Patwardhan's technique, or deliver by breech. All three are the possibility. Let us discuss. The abdominopelvic method is also abdominovaginal method, also called as the push technique. What happens in this push techniques? You need to have a good assistance, and the assistant has to push in such a way that they don't push it only with fingers, but sort of cup of the hand is made, and maintaining the flexion of the head, the push is given. Otherwise, the head gets extended, or there are possibilities of injuring the lower uterine segment. The second technique is the Patwardhan's technique, or the shoulder first technique, and the third one is the reverse breech techniques. Other options are fetal disinfection with the fetal pillow, using of the obstetric spoon, the snorkel. But let me tell you that all these techniques we do not use so commonly. What is being used very commonly and what the residents are very well trained is the Patvardhan's technique. Now, in the Patvardhan's technique also, you have to remember whether the back is anterior or whether the back is posterior. So if the back is posterior, there is more difficulty. But if the back is anterior, first and foremost, deliver the available shoulder, deliver the other shoulder, then you catch hold of the middle of the chest area, flexion of the tongue, trunk, and the breech is delivered, and finally the head is delivered. So that is a very, very, we are training nowadays in this technique is very well, your residents and the early career, all of the faculty are very well trained in this technique. So here you're seeing the first shoulder, the second arm is being removed, and then, the breech, and finally the head of the baby. So I'm going to show you a video here. Again, the credits are going to Manju Puri ma'am for this video. As you can see, the lower segment here is quite, sort of, you can see that the whole of the area is, may have been a little prolonged labor. And you can see now the flap is being created here. And the extension of the uterine incision with the help of the scissors here so as to avoid the injury to the uterine vessels. Here, now the shoulder was presenting at the incision area. So first, whatever the shoulder is presenting is removed. So this is on the surgeon side. A traction is given on that arm, and gently, you have to be very gentle when that traction is given. So pull it on your side, then the other arm is removed. So again, be very gentle while removing the arm here. Once that arm is removed, you need to hold the area of the chest with your both hands, and little bit of fundal pressure is required here so that the trunk and the breech is delivered. And finally, you can see the head is being delivered. So this is the Patvardhan's technique, which we prefer over the pushing from the abdomen. So when the back is posterior, actually it becomes a little bit more difficult. Here, the available shoulder is delivered, hand is introduced towards the fundus, and instead of doing the Patvardhan's technique, you can grip the leg and the breech is delivered first, and finally the head is delivered. So here again, the video will show that you are putting the hand up, delivering the breech first and the head last. It is much more easier actually, and a little bit higher incision if it is planned. You can very nicely go and pick up the legs and deliver the baby. So I have seen quite a few of my professors preferring the breech technique over the Patvardhan's technique and over the pushing from below technique. So this technique was actually preferred by my seniors quite a lot. So again, this is a systematic review for the deeply impacted head, and it looked at the risk of uterine extension infection, and they definitely preferred the reverse breech extraction. They found was quite good, and the push technique had a significantly higher mean blood loss as compared to the other two techniques. So now you move on to the next, difficulty, which is a floating head. Again, a major technical problem is delivering this fetal. Difficulty is occurring, and possibility of cord around neck, possibility of placenta previa, and is there in these patients. So first, what options we have when you have a floating head is either we can stabilize the head with fundal pressure and give incision at the maximum diameter of the head, or you can do an internal podalic version and do a breech extraction, or you could use instruments like a vacuum or a forceps to deliver the baby. Now, if you want to deliver by the cephalic, so what you can do is fundal pressure by the assistant to stabilize the fetus at the given incision on the lower segment till the extraction. So good fundal pressure, stabilization, holding that area with the neck of the baby, stabilizing with 2 fingers, and then giving the uterine incision at the maximum diameter of the stabilized head. That, you really need to have a good assist. Sometimes, the head can just slip off. And if it slips off, not to worry, not to panic. Just 2 days back, we had this incident. I had asked my senior resident to start the cesarean section till I reach, and the head slipped off. She panicked. But here, what you can do, immediately just catch hold of the limbs of the baby, the legs of the baby, and you remove by breech. So if the head slips, don't panic, just grasp the leg. So how to use a vacuum? Vacuum has to be, put at the maximum flexion point. I'll be showing the video where the vacuum is being used here. So as you can see, the vacuum is being placed, the vacuum cup, very nicely at the flexion point. We will remove the Doyne's retractor. And once the traction is given, the head can be easily lifted out of the incision. Actually, very good technique. More, if we are well versed with using the technique, I have seen one of my senior gynecologists here in Varda. She uses the vacuum for all her deliveries, not only the floating head, but all the deliveries she's been using. So it depends, the technique you are well versed with. But this, I can vouch that using a vacuum for a floating head actually gives you a lot of confidence, because this does not allow that head to slip away. You can use even the forceps. I will be showing a video for that. So again, when you're using the forceps, you can use a single blade, or you can use both the blades. In this case, again, you can see that both the blades are being used here. So now you can see head is visible here. The membranes are being taken off here. So hand is inserted below the head. So this is the lower blade, which is inserted first over the hand, which has been placed below the head. So in this way. And then the second blade is placed superiorly. Easy locking of the blade can be seen. You have to remove the Doyne's retractor here and lift off the baby through the incision. So both the vacuum as well as the forceps very nicely can be used as tools for delivering a floating head. And definitely other option is the internal podalic version and breech extraction. So Rashmi, I would like to ask you what was my time? Should I go ahead with this?
Please go ahead, madam.
Yeah. So this is another case I would like to talk of. You let me know, once my time is over.
Yes, ma'am.
This is the third gravida with placenta previa. She had a transverse lie at 36 weeks. Her cesarean section was done. 2.4 kg baby was delivered with difficulty, and there was a fracture in the left femur, and there was a lateral extension of the uterine extension as well with the broad ligament. Hematoma was there. She went into PPH. She was in shock. She was resuscitated and saved. However, we just thought of, could this be prevented? Especially the transverse lie, the fracture, and the extraction. So one thing to remember is a good planning. When you have a placenta previa, when you have a transverse lie, first and foremost, you have to, plan where will be your incision, what could be the preventing surgical steps if the patient starts to bleed, how to tackle the vessels, if prior to the incision you want to tackle, or after the incision, how to tackle the bleeding. That these are very important things to plan. If there is a bleeding from the bed of the placenta, how would you tackle those? What nutrotonics you'll be using? How to actively tackle the bleeders? So if there is a planning, then you have advantage, a lot of advantage, and you could be saving this patient. So if you're having an anterior low-lying placenta, here again the lower segment is poorly formed, it is quite vascular. There are two techniques. Either you could go below the placenta by insinuating the area where the free placental area is there. You rupture the membranes, go below and deliver. Or in cases where the whole of the lower segment is covered anteriorly by the placenta, then the placenta may be incised directly and deliver the baby. So both the cases are important, both the methods, you have to be well versed with, because sometimes you may not be able to reach below the placenta, and that in that case, you'll have to quickly incise and deliver the. So this is a comparative study, to surgical blood loss between both the transaction group and the non-transaction group. Definitely, if there is in the non-transaction group, there will be a less blood loss, and the neonatal, anemia will be less in these cases. However, if needed, you should be able to transact the placenta and deliver the baby. In case of transverse lie, again, a skilled surgeon, experienced surgeon is needed. Better to anticipate the possibility of some problem and ask for an experienced assistant as well. So assistant also has to be experienced. Incision on the lower segment has to be liberal. Feel the back, trace the back, hold the 1 feet if it comes, in your hand, and you deliver 1 feet, the second feet will come automatically, and you can grasp both the feet and deliver by breech. So again, be very gentle, do not panic. And if the hand comes out, sometimes you're not able to recognize the feet, and you may bring out the hand. You have to reposit it back and again go back and deliver the feet. So these are again, cases where you need not panic and be gentle in your approach. If there is an anterior fibroid, Dr. Puri was talking about this. So again, in fibroids, exact mapping of the fibroid just before C-section is very, very important. One should try and take an incision to avoid that fibroid as far as possible and deliver the fetus. Very rarely, one might have to go through the fibroid very quickly or perform a rapid myomectomy and then deliver the fetus, or do a classical C-section to avoid the fibroid. It is always advisable to, think of hemorrhage that can occur, and you have to take all the prophylactic measures when you are having an anterior form. Here is the last case I would be talking about, where, as you can see, there is if you are in a standalone practice, you open the abdomen, and this is a surprise for you. As you can see, all the vessels, are running over the anterior segment of the uterus, and really a sort of, threatening look of the uterus is seen. So what would you do? You're a standalone practitioner. What can you do? Typically, it would be a repeat LSCS, and placental tissue may be invading the lower segment, serosa, bladder, increased and tortuous vessels, as you can see, bluish purple mark, distension is there, and then bulging in that area. And definitely, this is the placenta accreta syndrome, which is here, and a dangerous situation to deal with. First and foremost, don't panic. Indecisiveness, hurry will compound the problem, and patience is very, very important. What you're in a dilemma, whether you would like to take out the baby, leave the placenta, whether you're going to do a hysterectomy, all these things will be going on in your mind. What you have to remember, that if you're in a standalone practice, do you have a competent team with you? Another obstetrician? Can you call somebody? Is there a surgeon anesthetist who can, convert this cesarean into a general anesthesia? If not, additional blood components, are they available? If none of these things are available, you're not confident at all that, you're able to deal with this situation, very, very much recommended is you close the abdomen without touching anything. Refer the patient to a higher center. where everything is available. Accompany the patient, communicate with the team who is in the higher center, and do not touch that lower segment at all. And only if you have all these things available, then you should go ahead and you should deal with this situation. So it's very, very important if you find such a situation in placenta accreta, not to touch this case. So I'll be skipping all this because I probably am crossing my time. So important take-home messages is that anticipate potential difficulties, avoid complacencies in high-risk cases, resources must be properly mobilized, good assistant, very important, trained staff, is the blood and blood cross-match, and is your incision plan, gentleness, all these are very, very important thing. Avoid force while delivering, induction delivery time, as Dr. Manjupuri was saying, from the abdomen to the uterus, you can take your time, but from the uterus to the baby, less than 3 minutes must be your aim. Good neonatal support is very important, and of course, a good friend or two nearby. You should be keeping good relations with your colleagues. They can rush to help you these, because this is one of the most dynamic surgeries, and you can have difficulty in any case. You have to be having good friends available who can rush to help you. Suggestions that there has to be a supervised training for second stage cesarean section, for floating head, skills and drills have to be practiced, protocols have to be there, and of course better training is required for the second stage cesarean section. So to conclude, anticipate, be prepared, seek help, do not panic, be gentle, reflect on what had happened, discuss, and finally share with others so you can do better next time. Thank you so very much for that patient listening. Over to the chairperson.
Thank you, Surekha. I think you have taken us on a virtual tour in a high-risk institute where all the difficulties were so easily managed, I think the lecturer, the on-duty people will really benefit. It is such a lovely talk, because these difficulties, they happen in and out in labor ward. We see the smallest difficulty to a very difficult case as like placenta accreta, what you saw. But the panic which people do is because there is at when they are in the labor ward, what happens is that it becomes much of panicky situation wherein people try to rush in, do things, and then it creates more complications, and that has a very bad impact on the maternal outcome also. So that should be really be reserved. A very good message which you have given for the low resource setting, that you just close it and send. If you send the patient and patient reaches properly to the destination, I think definitely the outcomes will change. So that is a very great message which you have given, and lovely videos, good practical tips, and it is really going to benefit. I think this was an eye opener, and with lot of, I think there are a lot of students also now, because cesarean section has become very routine. I think most of the people can do cesarean sections, but there are many few patients now, we have to actually tell them, let do normal delivery. Everybody can do cesarean section, but the message now what I'm going to give is that they should not consider cesarean section very easy, because all these complications can happen anytime. They feel, yeah, cesarean, so they will open, they will do it. But it is not such. Sometimes the cesarean section becomes very difficult. So you don't consider it always being easy. And the good presence of mind, a good senior guidance, that is very important at that time. You should not panic to call your seniors. At times, even it becomes very difficult for them to, open the abdomen, that because of the abdominal adhesions and all. And sometimes they take so much time to the baby delivery, and the fetal outcome changes. So in that situation, if you are there and you have a senior above you, at least try to deliver the baby going little higher up, and then you can call your senior to do the closure. But at that time, you need to inform. So that is also very good, that the baby delivery should not get affected, and that should not get prolonged when there are difficult cesarean sections. So I think really we need to optimize our patient's health and give a good maternal and fetal outcome. And great justice to the talk, as always, Dr. Surekha. Thank you so much for making me the part of this program. a lovely, insightful talk. Thank you.
Thank you. Thank you, Dr. Komal. You really have good, very high experience in a high volume institute, so thank you very much for those comments. So over to the coordinators.
Thank you. Thank you, Surekha ma'am, for an excellent and exhaustive talk. And thank you, Komal ma'am, for your comments. And I'm sure the delegates would have a lot of take-home messages. I would now request Archana madam to take over as a coordinator for the third talk.
Thank you so much, Dr. Monica. Good evening, all. It is indeed an opportunity. Thanks for the opportunity. And after listening to such great talk by Dr. Manjupuri ma'am and Surekha ma'am, we move forward to the next talk by none other than Dr. Mitra Saxena ma'am herself. She'll be talking on rising rates of cesarean section, a necessity. And it is an honor and privilege for me to invite the chairperson for this session, none other than the Deputy Secretary General Foxy, Dr. Suvarna Khadilkar ma'am. Can I have her CV? Madam is a professor and head of the department OBGYN and consultant endocrinologist and gynecologist, Bombay Hospital Institute of Medical Sciences, Mumbai. Madam is, of course, Deputy Secretary General. I already told she has been the Secretary of MOX 2020, Editor Emirates Jogi 2021 onwards. And you know how wonderful she has worked as an editor-in-chief of
Dr.
Journal.
Archana, let that be. We are all eager to listen to Mitra.
Welcome, ma'am. I would like to welcome you personally, ma'am.
Thank you. Thank you, Surekha. You are doing wonderful work.
Yeah, thank you, ma'am. Then over to you, ma'am.
Yeah, I'll take a minute to introduce Dr. Mitra. Are you sharing the PPT? Okay. So,
just say, Dr. Suvarna, what you know about me. Please don't read the CV. Just say 2 lines and then we can get on.
Yeah, I won't say much about what your achievements are. They are all seeing on the slide. But I only want to say that Dr. Mitra is a great person. She's a great speaker and she's a great academician and an obstetrician. So I always call her that you are Jagan Mitra, and she's friends of the whole Foxy world, you can say. She's almost everybody you see. Yes, Mitra is very friendly. She's very, very, always she will offer all the possible academic as well as non-academic help to everybody. So Dr. Mitra, just to give a formality, she's the chairperson of Practical Obstetrics Committee Foxy 21-24. And she has done several publications. She has organized several conferences, and she is member of more than 10 different societies, various awards. And all of us know that she is very much interested in high risk obstetrics. So over to you, Mitra. We are all eager to listen to your talk.
So please give me the rights to share my screen.
Bhavna, can you make a post?
So honestly, friends, to be a part of this wonderful webinar today, are you able to see my screen?
Yes,
we can see.
Okay. So firstly, I would like to congratulate my very dear friend, Dr. Surekha Taide, for conceiving and for arranging this wonderful, session where it's not just, presenting your own talk, but also learning along the way. So hats off to you and to Dr. Manjupuri, Dr. Parikshit Tang, you and Dr. Komal, and then my respected chairperson, Dr. Suvarna Khadilkar. I'm so honored that you are chairing my session. And after 2 wonderful teachers, the topic that I'm going to take is rising cesarean section rates. The topic which Rashmi told me was, is it a matter of concern or need of the hour? So friends, the previous 2 speakers have already told us the importance of, rising cesarean section rates, how a simple surgery can become so complicated simply because it is not the first time, it's multiple cesareans, and then of course, so many other indications. So definitely, this is an area of concern. and we will have to see whether we can justify the cesarean that we are doing. So I don't know why it's not moving. Yeah. So over, I'm not able to see my one side. Surekha, when I'm making it full screen, I'm unable to read the whole slide. So friends,
you can see what you have done. Probably there is some animation in it. So click,
yeah.
click, click.
Click more, ma'am. One more click and
ये जो ऊपर का
हमें दिख रहा है. आप एक और क्लिक करिए.
Ma'am, you are mute. Mitra ma'am, you are mute also.
Ma'am, unmute. हाँ.
Okay, so friends, we all know that over the years in, the cesarean section rates are rising all over the world. And that is more importantly, whenever it is not medically indicated, and that is the reason for the increasing cesarean section rate, that is really an area of concern. And frankly speaking, every cesarean that is done should be providing some maternal or perinatal benefits. Unfortunately, it is not. And that is where the area of, reflection and, taking corrective steps is really needed. So it's a procedure which is when undertaken for medical reasons, it can be the life savior for the woman and her baby. On the contrary, there is evidence that potentially unnecessary cesarean sections may put the lives and well-being of women and their babies at risk, both in the short and long term. And so we have to understand that actually speaking, cesarean section is not the normal mode of delivery. This is what I want to reiterate very emphatically, because ideally, the route of birth is the vaginal route, and cesarean section is supposed to be done when it imposes risk to the mother, baby, or both. If we keep this in our mind and then we take the decision, I'm sure we would be cutting down on the total number of cesarean sections that we do. And of course, our competence has to be improved so that we can tackle it with the primary or the complicated cesarean sections. Now, let us look at how it, why the rising cesarean section affects the different countries, whether they are low, middle, and high income countries. And because of the different settings, they could be in low, middle income countries or high income countries. The settings can be very different, from a setup which has everything to something which has, where there are so many deficiencies. So it all depends on the human or financial resources available. Very importantly, whether the team has the capacity to perform cesarean section safely or not, and manage associated complications. So friends, I think all these things are really, really important when we are, doing a cesarean section. Every cesarean section is very different, because what our worthy speakers have spoken before me, they've highlighted how any single simple thing can become very difficult. So when you are in your own setup, you have to make your setup your as minuscule thing as your operating table, your anesthesia machine, everything has to be perfect. It's not just a cesarean. You have to be very careful in to manage any complications. Now, I'm just going to put down all these important indications of cesarean section in with respect to the mother and the fetus, which are known and which are actually justified. So whenever there is an emergency in the form of maternal hemorrhage, uterine rupture, or perimortem cesarean section where you have to do, or it's a non-emergent situation, yet it is indicated. So we find that here, we have to be competent to deal with the surgery, and there is no question about, avoiding the cesarean section. Similarly, for fetal conditions, when there is an emergent cause, cord prolapse or fetal prolonged terminal bradycardia, malpresentations, multiple pregnancies, macrosomia, here everything is fine. But those two things which are put in the red box, they show those areas which are not objective, but quite subjective, where there is, ill-defined labor dystocia, non-progress, failed inductions, and some, there is some difficulty in translating the guidelines into practice, or defining fetal distress. So, these are the areas where there could be an extra cesarean section provided if you are not following the norms. Now, if we take a look at this slide, it kind of summarizes that every cesarean section, even it's the primary cesarean section, can have short-term complications and long-term complications. And of course, with the rising rates of cesarean sections, we are going to have increased maternal morbidity and also fetal problems. I'm going to be on the maternal side. Very importantly, we all are very much aware of the placenta accreta syndrome, cesarean scar pregnancy, and all the difficulties with my speakers have already mentioned in entering, in technical problems. And also we will address the problems which happen to the babies because of increasing cesarean sections. Now, if I would just mention quickly, these are the complications a simple cesarean section can also have. Even a primary cesarean section, there could be complications in the anesthesia, failed anesthesia, high spinal, hypotension, post-op pain, neck pain, fever, UTI. All these things are known. So it's not that a cesarean section is easiest and it is the norm. Similarly, intra-op, you can have injury to all the, neighbors, the bladder, ureter, bowel, or atony, and lacerations, extensions, depending upon, suppose if it's a difficult extraction in, as already mentioned. So I'm just letting you all go over all these things. So when we start, every time, at least for myself, whenever I do a cesarean, I'm extremely conscious of the fact that all these complications can happen, even if it's a primary, even if it's an elective cesarean, indicated elective cesarean section. I have to be prepared that we do not introduce infection, have endomyometritis. We take care of everything which is listed over here so that these short-term and long-term complications are reduced. Now, looking at the world data, we see in the last 3 decades, from 7%, it has, current rates are almost something around 21%, and it is projected that it's going to increase to 29%. Now, there is a lot of debate in the international scenario and our own country, that what is the exact cesarean section rate which is acceptable. Friends, I know each one of us is, having our own perspective, but most importantly, we have to understand having a very low cesarean section rate implies that there is something like unmet need. So there would be increased maternal morbidity or fetal morbidity if you are not able to do cesarean section, because you cannot have very, very low cesarean section rate. Similarly, on the other side, if you have a very high cesarean section rate, it's not right. It is not expected that your cesarean section rate should be 50, because then you are overusing it. So somewhere we have to define that what should be the acceptable cesarean section rate in our practice, in our state, in our country. So let's just quickly look at the global data. We all know that there are countries which are actually very high on the, on the right side, Italy, Brazil, who have very high cesarean section rates. And then on the other side, in the less developed countries, we have very low cesarean section rates. We have to be very aware that these disparities have actually alerted the WHO, the FIGO, to come out with good guidelines and strategies so that we maintain an acceptable balance. Now, looking at our own data in our country, NFHS has provided, and it's very heartening to see that the incidence of institutional deliveries overall has mightily increased in our country, which is a very, very good change for the practice of obstetrics. Yet in our own country, we have a lot of divide between the rural and the urban, the public and the private health facilities, and also different, states are having different practices. So it's a vast country. Types of hospitals vary depending upon the geography, economics, availability of trained personnel, public, private, trust hospitals. And you cannot have one guideline including all clinical scenarios. So most importantly, individualization has to be necessary as per the demand of the situation, and minimum standards should be maintained. Now, let us see in our country what happens is, what we see is that in some states, the percentage of cesarean is very high, like Telangana is 61%. And in some states like Bihar, Meghalaya, and Nagaland, it's very low. So we have to, give this a very serious thought that what is happening. And let me show you this, that in the upper part are the areas where there is very high level of cesarean section in the private setup, the blue color code. West Bengal, Jammu Kashmir, Telangana, they're, at the top of the ladder. But even their public sectors, which is shown in the yellow, is quite high, 42%, 44, which is much higher than the accepted average. Similarly, in the lower part, we have Bihar, Maharashtra, Gujarat, Mizoram, Nagaland, where the percentage of cesarean section in the public sector is quite low. Imagine in Bihar, it's only 3.6%. So there is definitely a discrepancy and there is unmet needs. Yet, in the still again, the private sector is leading. So we have to consider that with all this disparity happening, what is the reason? Why the cesarean sections have suddenly, kind of increased so much? We all know that now there is increasing maternal age. There is very high, infertility patients being treated, IVF and obesity. They're all medical diseases now. Previously, very seriously ill patients would never get pregnant. But now we are having women who are having transplanted kidneys or respiratory diseases or cardiac diseases who are all venturing into pregnancy, and they become high risk. And, there would be cases where there would be increased cesarean section use. And of course, very important is the sector of previous cesarean section. Now, coming to the patient side, patients will behave as per the fashion of the country. So if it becomes very fashionable that, pain is very difficult, it's very fearful to have vaginal birth. So we find that a lot of our educated patients, they are so anxious, they are not willing to bear pain. And we find a very increased demand of maternal request and also more cesarean section. And they consider that vaginal birth is unsafe, which is very, very sad. And they consider that cesarean section is a safe mode. If we look at the reasons why obstetricians have, resorted to increase cesarean section, a lot of it is cited that it is because, when the patient is not agreeing, why should we bother? Why should we kind of, they're not going to listen. So, we'll have to comply. And also, when there is less experience of delivering by the instrumental, vaginal birth, where our experienced seniors would, save the cesarean section. And right now, the juniors, the new obstetricians would never venture into, converting instrumental delivery into vaginal birth. They would rather go for an earlier cesarean section. We are blamed. We are accused of, resorting to cesarean sections for financial gain. And most importantly, it is the legal consequences and the litigation secondary to adverse outcomes by vaginal birth that the obstetricians are most fearful. So basically speaking, we have to give a very serious thought to every patient who deserves or needs a cesarean section. It has to be seriously, decided. It's not just because patient is saying that we do, or because we are afraid we should do. We have to justify the reason why we are doing. Now, even if we were to look at the indications in the global scenario, we find if we would give a thought to the primary cesarean births, which amounts to at least 15%, 50% of the increasing cesarean section rate, we have to understand that once there is a cesarean section, now because in, world over, at least in our country, the incidence of TOLAC has remarkably come down. And we find that if there is a previous cesarean section, the chances of a repeat cesarean section is very much increased. So how to decrease the cesarean section rate has to be really, put in practice, and every primary, her labor has to be the place which has to be given maximum importance. Because, just doing a cesarean section for a non-reassuring fetal status or arrest of dilatation and, unneeded, uncalled or untimely inductions. So there we are going to land up with increased cesarean sections. However, if we are doing for malpresentations or indicated cesarean section, I'm not talking about that area. I'm only talking those situations which can be modified. Now, we have to understand that consequences of cesarean section is, do we have, better maternal and fetal outcomes if our rates are high? The answer is no. It has to be acceptable. It has to be justifiable. And then only, we will be decreasing the maternal morbidity and the neonatal morbidity. Now, let me take you, we all have faced all these, outcries by the media simply because, we are defamed in the society that the cesarean section rate is very high, very high. So we have to reiterate, we have to look at our own, practices, how we can do the best, job in our scenario, and how we can, promote and inculcate this, culture of valuing the decision making of cesarean section. That is most important, I feel. Now, I will quickly take you through all the risks in even a primary cesarean section. So, when a patient comes to you and she wants cesarean section at request, no, I am not ready to take the pains, it's not safe. I think it's a time that as an obstetrician, we have to spell out all these complications which can happen even in the most simple cesarean section, all the maternal and the fetal complications. So we have to know that every cesarean section, even if it was a simple cesarean, can have short and long-term risks. And also these, complications can affect the health of the woman and the child in future pregnancies. So there are lots of articles which are, spelling out these risks and benefits of cesarean section for mother, baby, and subsequent pregnancies. And it's really important to realize that every, decision is of utmost importance to that patient. She may not turn up to us, she may go to somebody else, but for her, the decision of cesarean section is very important. Now, we are all very much aware now that previous cesarean section has, kind of blown into big proportions, a kind of epidemic, which is placenta accreta syndrome, cesarean scar pregnancy, and in a later date, the isthmocele, which is responsible for the abnormal uterine bleeding. So I will like to, I'm not going to spell out much, because we all are aware that this is the nightmare of modern obstetrics, like what Dr. Surekha mentioned. Ideally, we should not be caught unawares, because we are obstetricians, and if there is a previous cesarean section, we in our antenatal checkups should have seen where the placenta is implanted. We have to make an active effort to rule out placenta accreta syndrome, so that we are not caught up with those horrifying images which Dr. Surekha showed. But still, we have to remember that this is, as the number of cesarean sections keeps increasing, the incidence of placenta previa and accreta syndrome keeps on increasing, and it's really, really important. I mean, it would be blasphemy if somebody would say that, oh, I didn't look for this. I'm sure every obstetrician in our country is now very alert to this complication, and nobody would like to get into trouble. My talk was very dry, so I tried to put some colorful pictures so that each one of us can remember that how difficult the cesarean can become if we are confronted with previous cesarean, with adherent placenta, and that would be the worst. These are those which are, you already lost the chance, because this is a high-risk patient, and mother can, with all the precautions, land up in the ICU or on the ventilator. So never forget that if we do a cesarean section and we are subjecting her to, increased problems for adhesions, hemorrhage, rupture, all these things. I just put this so that we never think that, okay, I'm just doing one cesarean. What will happen in the next time? We have to justify this time itself. So also, suppose we do the primary cesarean, do we not confront paralytic ileus or bowel complications? We have cases there could be subacute intestinal obstruction or unknown bowel injury or peritonitis. So friends, never think that, it's a simple 1 hour or 40 minutes job or a 30 minutes job. There are all potentials for complications of bowel injury, surgical site infections. Of course, in repeat cesareans, the chances are more. Obesity, the chances are more. But we have primies also who come back to us with indurations and adhesions and sinus formations and, real problem of wound dehiscence and restitching, etc. So it's very important to give decision-making the full importance. Now, quickly, I would like to say, Compared to vaginal delivery, a cesarean delivery increases the risk of severe acute maternal morbidity, and the hemorrhage requiring hysterectomy or blood transfusion, uterine rupture, anesthetic complications, obstetric shock, arrest, acute renal failure, need for intubation, venous thromboembolism, major infection, and in hospital wound disruption. Everything of this is possible. You would have heard one of your colleagues, she did a very nice cesarean section, and on the third day in the ward, patient just died because of pulmonary embolism. Maybe she was an obese patient, and this thromboprophylaxis was not done, and we've had these very healthy patients with easy surgeries, just not giving us time to resuscitate them, and they die because of any of these complications and hematomas. So now let's look at the long-term consequences. I've already mentioned, but placenta accreta, placenta previa, isthmus seal, and all those things which I've already mentioned. These are some things which are going to add to the maternal morbidity, and we all have to be conscious about this. Now, let's quickly look at what happens to the baby. Is every baby delivered by cesarean section very healthy? This is, when you do a cesarean section for a fetal indication, definitely that is the best outcome, because that is the way baby will come out alive and be resuscitated or looked after by the neonatologist. But when we have done a, induction and it's a failed induction, and we land up with iatrogenic prematurity, what about it? Haven't we increased the morbidity and mortality of this neonate? So friends, cesarean deliveries are not a panacea for all. And very importantly, we have to understand and explain this to the woman who's asking for cesarean section on demand. This is a very important thing I would like to spend a little bit time. That is the microbiome. It has been studied that when the baby is born through the vaginal route, the gut microflora of the baby is that which is of the vaginal microbiome of the mother. Now, when the baby is delivered by cesarean section, the microbiome of the baby's gut is that of the mother's skin. And it has been shown that, this is a very disruptive event. We actually do not realize the harm we have done to the baby by, not giving it a good immunity. We have kind of compromised the immunity of a neonate who has come by the abdominal route, not because this was medically or actually indicated, but just because it was for some convenience of the mother or the obstetrician, because we have actually deprived the baby of this wonderful immunity which the baby's gut would have received, because it had it come through the vaginal route. And also we have to realize that this is very important for the, in fact, when we look at the data, we realize that the long-term consequences on the baby's health in the form of non-communicable diseases has been linked to this increased cesarean section. So cesarean birth is linked to obesity, to non-communicable diseases, asthma in the neonate in the later life. So friends, today what we do a cesarean section, if it is justifiable, okay, fine. But if it is not, then we are going to give another generation lots of problems in the future. So immediate impact on the baby, of course, if there is prematurity, we are going to subject the baby to, CPAP or NICU admissions, needing respiratory support and unnecessary interventions. Also, we know that cesarean section, there will always be poor breastfeeding practices and difficulty in establishing the lactation. And as I said, if we subject the baby to only the skin biome of the mother, we are actually subjecting the neonatal physiology to altered immune development, increasing the risk of allergy, atopy, and asthma, as well as greater likelihood of childhood obesity and another host of problems of NCD. So, friends, we all know now this. I think none of us would have been left untouched. And thanks to Dr. Mike Robson, Dr. Pai, Dr. Sureka, that all of us have really gone through the Robson's criteria 10 group classification. And we all know that the group in the box 1, that is the primary spontaneous labor or induced labor, here is where we can actually control the cesarean section rates and, give a good chance to the mother to, have, good future outcome for herself and baby without actually compromising the baby. Because group 5, which is the group of previous cesarean section, see, that contributes maximum to the overall cesarean section rate of any institution. Because when there is high number of patients who come for previous cesarean, they are all going to land up in cesarean section. So it's really important, and I'm sure that each one of you would be well versed with this criteria. And just to show you that in this whole summary, the overall cesarean section rate is 23.5%, of which the group 5 is contributing 10.9%. So almost 50% of the cesarean sections have been contributed by group 5. So previous cesarean is where, if we could reduce the number of primary cesarean, definitely this would decrease lots of complications of cesarean. The technical difficulties would also be lessened. So my take-home messages would be that, the cesarean section has to be reserved for only those which are actually justified and medical indications. To, improve our own practice, we have to classify our deliveries in the 10 groups, which are all mutually, mutually exclusive and totally inclusive. Every delivery will find a place in the 10 group classification. And if we do that, we would know, what is our practice? Are we going according to the guidelines? Are we doing unnecessary inductions? So that's a very important. Audit is a self-improving exercise. We have to understand that cesarean section reduces the maternal and neonatal morbidity and mortality significantly when it is done under proper indications, while at the same time, it can be of harm to the mother and the child when performed contrary. Also, as I already said, that the rising NCDs and increased cesarean deliveries, they go hand in hand. So today, what we do is going to have an impact and a major health threat to the future generations. And we really have to take, importance to that. And unfortunately, the modern societies have started perceiving cesarean section as a normal delivery mode because they are afraid to take over pain. So I would reiterate myself and all my colleagues that let us put some more time, let us convince our patients, and let's apprise them of the problems to their own health and their child's health, so they do not, go in for the number of cesarean sections on demand comes down. Now, actually, I had also taken up this guideline from WHO, which has recommended the non-clinical interventions to reduce unnecessary cesarean sections. If I have some time, I can take you through these 4-5 slides. So because it is really important, we talk about cesarean sections, rising cesarean section rates. We all know at personal level how difficult it is to convince patient on this side or the other side. If they don't want a cesarean section, they will go mad and they will not give you the consent. And if they don't want to go from normal delivery, they will not give you, they will not allow you to give them an opportunity to deliver vaginally. So this guideline by WHO has some non-clinical interventions for obstetricians, midwives, and general practitioners, and also the health policy makers. So it is important that, some things are now coming into play because of, it's like you do something, a practice, if it is not right, it's going to raise alarm. And then when the law is made, it kind of suffocates you. So basically, if we do not follow the guidelines, we do unnecessary cesareans, we cause, authorities to, be alarmed, they have to take an action. So I would like that the non-clinical interventions to reduce cesarean sections are targeted at the level of the woman, at the healthcare professional, and also the health organizations and the facilities of the system. So it's very important that educational intervention for women has to be done. We have to start doing childbirth training workshops, nurse-led applied relaxation training programs, breathing exercises. Couples have to be educated. And, it is not that on the last day you can do it. It is during the antenatal period that this has to be carried out very methodically with the help of your own staff or your attendants, that this has to be done. Now also when we are doing the managing the labor, we have to follow the clinical guidelines, and it is coming into play. It is seen that if there a second opinion is taken for cesarean section, the incidence decreases. I don't know, but then really it is kind of having somebody play a cop on over you, but yet it has been recommended as a high certainty evidence that a mandatory second opinion, when it's going to be implemented by our government, we really don't know. Now, audit and feedback is very important, and the 10 group classification system, all of us must understand whether we have a small volume practice or a high volume practice. If we do the audit, we know where we can improve our practice. And of course, if we do justified cesarean section, then a cesarean section rate of 20% or a 30% is justifiable. Suppose you're a high risk unit, you are going to get all the high risk patients. You have NICU, you are going to have, smaller babies, higher cesarean section rates, and it's all explainable. Now, also, it has been seen that when the midwives are there, they are tackling, the cesarean section rates are less. So, it is including the midwifery into our practice, midwives, and Government of India is actually seriously thinking about all this, how to, get them into the mainstream and decrease the cesarean section rate. Also, the financial strategies, we have defamed that we are charging more for cesarean section. So we personally, lots of people have these strategies that their vaginal births and cesarean sections are equally placed so that we cannot be blamed. Yet, the people look at us with some, disbelief that it is the financial gains because of which cesarean sections are done. Now, one point already my previous speakers have said that cesarean section at full dilatation is something which is very difficult to tackle. So better that this should be avoided, because all the complications, all the difficulties will be much higher. So as an obstetrician, I would say this is a red flag, because it is the most challenging task, especially when you are alone at an odd time, no help, no pediatrician. And, you may be quite stranded. So yes, cesarean section at full dilatation, it would be better to be 1 or 2 steps ahead of getting into actual problems with all those complications mentioned. This is the statement of cesarean section by, worded by our president, Dr. Jaideep Tang, and he very nicely debates that what is the ideal rate. Ideal rate is you cannot, restrict yourself into some percentages. It has to be thought out. What is important for the woman and her baby is the ideal rate. I would request everybody to go through this, and it's really very nicely worded, and for us to reflect and practice. Final verdict is, as per me, it's not somebody from some book. I feel that this decision of cesarean section should be not too late or very early. It has to be judiciously indicated cesarean section. It has to be performed in safe setup. Well, if I have a small setup and I'm landing up with placenta accreta syndrome, nobody can defend me if my patient has atony and I lose the patient. And, so you have to see where are you practicing, whether it's a public, private, or you have everything. You have ICU, go ahead. You have a team, go ahead. Otherwise, you should know what cesarean should be done. Very premature babies, you don't have a NICU. Why are you doing the cesarean? Why didn't you do an in utero transfer? So basically, good obstetrics is always very helpful in getting the best result, because finally, we want a non-compromised mother or baby. And for a good outcome, we have to have antenatal preparation for safe birth, follow the labor guidelines, audit our own records, decrease the cesarean sections in primaries as much as is possible. I think that is the way forward. Thank you very much. I hope I've not put you all to sleep. Thank you so much, Dr. Surekha, for giving me this opportunity. It gave me a wonderful time to, compile whatever I could. Thank you.
I think it was an excellent lecture, Dr. Mitra. Really, you have covered everything. It was quite exhaustive, and you have not left any aspect of rising cesarean section.
One second, Dr.
rate
Suvarna, sorry.
untouched.
I want to also give credit to my very dear friend, Dr. Kiran Mai, because she has given me a lot of input for this preparation, and
Data,
she
yeah.
went through my slides also. And thank you so much, Kiran. Yeah, please, sorry. I had it in mind, and then,
No, it's
sometimes it
okay.
slips.
Yeah, of course, Kiran Mai is always helping too.
Yeah.
So I think when I had first done one publication way back in 1997, and that time I had noticed the rising cesarean section rate in multiple pregnancies, and it was almost doubling every year, and it reached almost 30 to 40%. And I had just said that in future the cesarean section rate in multiple pregnancy, will it be 100% and a question mark? That was my conclusion in 1997, and we really have almost touched that, if not little bit less than 100%, but almost all twin because what happens is obstetrician gets distressed or stressed out whether these multiple babies will come out healthy or no. If it doesn't come, it doesn't cry, the second baby. And so this was a multiple pregnancy. But overall, even the singleton pregnancies, I compared it with singleton pregnancy. So I know the data of 1980 to 1990, my own hospital data was stable at 7%, the singleton pregnancy cesarean section rate. And then I think the time of active management of labor came in, the partograms and the fetal distress and everything all went in, where everybody, and also the medico-legal, fear in mind of obstetricians that we don't want to wait long, otherwise we will be questioned and we will be sued. So I always used to tell people that there are 3 indications: maternal distress, the fetal distress, and obstetrician's distress. So we should avoid getting stressed out. We should avoid, as you rightly said, take the decision very judiciously and the balanced one, so that you don't land in any problem. And if there is any problem, you can nicely explain to the relatives of the patients that, look, I tried to deliver vaginally, but you can't, we can't go ahead. There is a danger for both maternal as well as fetal life. So most people do agree. And there are 2 groups of patients. One, as you said, they insist on vaginal delivery. The other one insists on cesarean section. And obstetrician doesn't know how to tackle these situations. But you have made it very, kind of very informative, and you have given taken into consideration all the guidelines. WHO, and I always say WHO had given a standard rate, say 15%. But I said for one pregnancy, for the patient is 100%. The patient wants her life and her baby's life, and that is 100% she wants. So we can't fix a 15%. So we had a big meeting, and then I think what statement you showed, finally I think Dr. Jaideep Tang took that statement, and he has put up as a position of our Foxy regarding the cesarean section there. I think it's a wonderful deliberation that you have done. You have covered everything. And I always remember my teacher, Dr. Vijayakar, she used to say, we used to say, ma'am, she's not progressing. She used to say, the trial of labor is not complete unless you have waited for 2 hours after full dilatation of the cervix. This is what she used to say, and we used to get very worried. 2 hours, and then she has good pain, and then if she doesn't deliver, then you think. So we used to head for a lot of second stage cesarean sections if she wouldn't deliver. So I think today we can't apply the same rule because of several reasons. But as you rightly said, the primary section is the one which has to be, most important, where we can do something and prevent the previous cesarean section. As you said, 50% of them are contributing to the sections. So thank you so much. Once again, Surekha, I think the whole program is excellent. Dr. Rashmi has been really working very hard, and with her team, I can see so many of Monica, and the previous speakers and chairpersons were excellent. Thank you so much.
Thank you. Thank you so much, Dr. Suvarna.
Thank
Really,
you very much, both of you. I must say that this whole webinar we must focus on experience part, I think, here in this whole of the series. Both the faculty and the chairperson have shared the experience so much that it makes it more enriching. And there we are now going towards, excellence. So the evidence, experience, and excellence series, the 3E3, has been very well taken up by the whole faculty. And I would like to thank all of the faculty very much for taking so much efforts and pains to make this a success. And I would like to thank Dr. Rashmi for being the convener and talking and coordinating with everybody, the co-conveners, Dr. Jaya, Dr. Monica, and Dr. Archana. You have made this a complete success. And thank you very, very much for with us today.
Thank you, Surekha ma'am.
And
thank
one
you.
thing I would like to add that we have around 340 viewership at present. So thanks to all the esteemed chairpersons and speakers and the coordinators.
Thank you.
Can I congratulate you, Dr. Suvarna, to become the president of MOGS, which is such a prestigious post, and with
Yes.
your
And I'm coming
smiling,
over to meet you
melodious,
tomorrow.
personality, I'm sure MOGS is going to shine.
So, Anna, ma'am, I'm coming
Your
tomorrow.
blessings, please, all of you, please best
No
me
blessings.
Congratulations,
our
for a
joy we
successful
will be
year.
with you. Thank you.
Anna,
Thank you,
we are coming
Surekha.
to Mumbai tomorrow.
Tomorrow. I know you. The same
Laura,
day Nagpur is
yes.
having installations. So I could not involve many Nagpur people for the program.
No. Tomorrow I'm coming for our clinical research committee program. And
Oh, yes, I'm coming there
you
as
are
well.
our
Yes.
guest of honor.
Yes, right.
Okay.